Today we are doing Sarah Has Questions. We took a field trip. We sure did. We are in Cary, and we are at the Wake Med Cary location, and we are in the urogynecology section of the Wake Med Cary location. And I'm with Jen Harrington, and she is a pelvic floor therapist. And we wanted to do a pelvic floor episode because what exactly is pelvic floor therapy? I'm Sarah King, and I have a lot of questions. What exactly happens when you orgasm physically? Will popping a knuckle or a joint give us arthritis? What can we learn from our poop? The size of your body doesn't necessarily indicate your measure of health. Yes. And what are your thoughts on that? Cleansing. Do we need to do anything special to our nether regions? In this show, I get to ask all these questions to Wake Med doctors who happen to know everything about everything. Sarah Has Questions is a production of Capital Broadcasting Company and Mix 101.5. It's presented by Wake Med. Jen.
Yes.
Thank you for being here.
Absolutely. Thanks for having me.
So if I were to come in, if my gynecologist says, you need to look into pelvic floor therapy, what is it? Like, I really don't understand it. Like, start from the beginning.
So have you ever had physical therapy for anything else before?
No.
Okay, so physical therapists, we're the musculoskeletal experts of the body. Okay. So we take a look at the human body and we see how the joints are moving, how the muscles are moving. We may test strength and endurance. And if somebody's having pain or dysfunction, we try to evaluate, pick up on deficits, and then try to treat what we find to help resolve whatever their problem is.
Okay.
So with pelvic floor therapy, we have extra training. So we do general physical therapy. That's how most of us are trained. But then we're also trained specifically in how to assess the pelvic floor, because the pelvic floor is similar to other muscles in the body. You know, your arm muscle, you can kind of bend your elbow, straighten your elbow. Mm-hmm. You can see those muscles. You can see your arm move. The pelvic floor is hidden inside the pelvis. So we don't have that same visual feedback necessarily. Mm-hmm. So a lot of times people are disconnected from their pelvic floor and don't know how to control it, even though in theory they can. Mm. So pelvic floor therapy, I sometimes tell people, you know, if you could combine a general physical therapist and a gynecologist into a blender.
Oh, that makes sense.
That's what you might get with pelvic floor therapy.
So how do you know you need pelvic floor therapy? What are some signs that pelvic floor therapy would be a good option for you? Yeah.
I have a very, very strong bias that I think every human would benefit from pelvic floor therapy.
You know, my therapist says the same thing. Not my physical, like my brain therapist.
Absolutely. Well, and it's all connected, right?
Yeah, right.
In some way, shape, or form. So the pelvic floor, it's the floor of the core. So for some people, pelvic floor dysfunction may present as just like a feeling of core weakness and feeling like maybe you're not strong enough to do the things that you want to do, or maybe back pain. It might be pain that gets worse with exercise, and you've had maybe other traditional physical therapy, but the pain hasn't resolved. Sometimes it can be the pelvic floor that might be causing the problem. Any type of bowel dysfunction, bladder dysfunction, so urinary urgency, frequency, any leaking that might happen with coughing, laughing, sneezing, or with an urge on the way to the bathroom. Bowel dysfunction, so any constipation or straining, or leaking stool or passing gas when you don't mean to. Okay. And then sexual dysfunction. So if there's any pain with intercourse or inability to have an orgasm, or maybe just changes in sexual function over time, erectile dysfunction, those are all things that you can kind of encompass with pelvic PT.
Okay. So let's say my gynecologist says you need pelvic floor therapy. What's going to happen during my first visit?
Yeah, sure. So most of our first visit is spent really talking and developing rapport and learning about your history. If we have access to your medical record, we will review that ahead of time, and then we'll have a lot of conversation. We ask questions about bowel function, bladder function, sexual function, if there's been any injuries in the past. I like to find out what people know about pelvic floor therapy already, or if they don't have any idea what they're getting into. Because sometimes people are referred maybe for just back pain, and they come in and I suspect it may be their pelvic floor. It can be surprising for somebody for me to say, you know, I think we should assess your pelvic floor.
And they're like, wait, but my back hurts.
Yeah, and so we try to really educate people on their anatomy, teach them where things are, why things might be referring pain someplace, or why it's relevant to assess those things.
Got it.
So typically for our assessment, after we do a lot of talking, we do a physical exam. And the exam is mostly external. So we take a look at maybe the back and the hips, and we see how different joints are moving. We might test strength. We may check any scar tissue mobility. So if there was ever any abdominal surgeries before, we may check to see how the scar moves.
I see.
Some of us are trained to check to see how well the organs might be moving sort of within the body and the fascia. So we may assess those things as well.
Are you
externally.
certified in that?
I am.
Oh, she's special.
You know. And then after we do that, often what we do is a brief internal assessment if the person's willing to do it and if it's appropriate for what's going on with them. So for the internal assessment, if that's something that we're going to do, again, we talk about it a lot ahead of time. We always educate people with the pelvic floor model to try to teach them about it, which I will do in a second.
Okay.
And we explain, again, why we want to do the things that we want to do and try to connect the dots for people, especially if they don't understand.
Okay.
If somebody absolutely does not want to do that, you can just tell by their body language or how they're interacting.
Yeah.
Nobody's ever forced to do anything. So if somebody would rather decline it, they can always decline it. A lot of times the therapist might just pick up on that independently and say, you know, this is something we might do for the future, but we'll talk about that later. I just wanted to let you know kind of what it is just in case.
Yeah.
And then for the internal assessment, if that's going to move forward, it's not the same as a gynecologist in the sense that there's no speculum, there's no stirrups, there's no gadgets.
Okay.
It's a glove lubricated finger, and it's just because we can't see the muscles because they're tucked up inside.
So you're going to feel around and see if there's tightness in places.
Correct. So similar to if you had like muscle tension in your neck, and a therapist might want to feel that muscle to see, is it stiff? Is it strong? Is it coordinated? Same thing with the pelvic floor, but the only way to access it the most accurately is to do the internal assessment. This is the pelvic floor model. So all the white out here is bone. All of the red kind of on the outside is going to be more muscle. This red is an artery. So if we tip into the pelvis this way, you can see the organs that we have down there. So, and this is a cisgender female pelvis right here. So we've got a bladder that's in the front. We've got the uterus with the ovaries that are over here, and then we've got the rectum that's kind of all the way back in there.
No, we took it out.
So yeah, if we take these guys out, I'm going to hand those over to you. Okay. So there we've got kind of the bowl of the pelvis. So when we talk about doing an internal assessment of the pelvic floor, these are the muscles that we're looking at. So if we flip over this way, you can kind of see all these muscles on the outside. The misleading thing about these models is that they always kind of tuck in these superficial muscles under the pubic bone in the front. But actually, the superficial muscles live a little bit more up here. So the clitoris isn't like all the way underneath you. It's like more up there. But it fits nicely down there. So all of these superficial muscles on the outside are mostly in charge of sexual function and arousal. And then we've got this little intermediate layer here that helps to kind of clamp and close things off to prevent leaking. And then we have this deeper layer here that's kind of like a hammock that helps to support the internal organs. It helps to stabilize the spine. And then from the inside, you can kind of see those hammock muscles again, going from the front all the way back right there. And then we've got the obturator internus on the sides over here. And that covers up this hole that's kind of at the front of the pelvis. This is called the obturator internus, and it's a hip rotator muscle, but it's actually part of the pelvic floor. And then the thing that you can't see with this model, because they always cut it, which makes me so upset, is that obturator internus that's on the inside, it comes out behind your sit bone right here. You can kind of see the little nub right there. And then it actually attaches to the side of your hip on the outside. So it's inside the pelvis, and then it sneaks around outside to the outside of your hip. So when we do our internal assessment, again, if we decide that we're going to do that, it's a glove lubricated finger, and we kind of go in and we actually feel the muscles. So we can kind of tell what's going on with them. So with a gynecologist, they're going in, they're looking for the cervix, they're kind of testing the integrity of all of that. They may be doing a pap smear. With pelvic PT, we're not going that far, and we're not really addressing the organs. We're addressing more of the bowl of the pelvis.
Got it. When you said the muscles are coordinated, what do you mean by that?
So muscles kind of all over our body need to be coordinated to be able to perform certain movements. So if I need to be able to flex my elbow and extend my elbow, I need this muscle to listen to my brain when it tells it to do that. If my arm maybe was stuck like this and I tell it to squeeze, but it lets go, so that would be an incoordination.
Oh,
so
and you can fix something like that?
Potentially, yeah.
Interesting.
So with the pelvic floor, we need it to be able, it has a certain amount of resting activity all the time. That's why we're not constantly losing contents when it's not.
Thank God, that'd be horrible.
But sometimes these muscles maybe become too active. And if they're too active, they might not squeeze well, they might not relax well. So they may, we may have trouble emptying the bladder or trouble having a bowel movement. So it may be more constipation. Or the muscles may be so relaxed that, again, they need to be strengthened because they're not holding things back.
They're leaking.
Yeah.
Things are leaking.
And leaking, I think a lot of times people think that leaking automatically means just plain old weakness and I need to strengthen. But for a lot of patients that we see, there's a functional weakness, but actually the muscles may be too tense and too active. And that's the tricky part.
Yeah, well, I heard once that if you held your muscle like this forever, eventually you just get tired.
You get tired and your muscle kind of adaptively shortens.
Yes.
And it might become weak through the rest of this range of motion.
Yes.
So same thing with the pelvic floor.
Interesting. Okay.
Yeah.
We're going to go through an external exam. I'm not doing the internal exam. You're going to have to actually make an appointment for that. But Jen, so what would you do? You said you start with an external after you do your consult, which we just did. Okay. So what's next?
So I'm going to have you go ahead, turn around and face that door there. And I'm just going to check your alignment here. So I'm going to go ahead and just kind of look at your pelvis and start to see if there's anything that looks glaringly obvious that's not even.
If you need to lift my shirt up, I'm fine.
Yeah, you're okay. Any pain if I press right in here?
No.
Good. Go ahead and bend forward as far as you can comfortably. Good. And then come back up. Any pain with that at all?
No.
Good. And then go ahead and bend over to the right side. Just kind of tip over. Good. And then back up. And then go over to the left. Good. And then back up. Any pain with any of that?
No.
Okay, perfect. Then go ahead, bend backwards for me. Perfect. And then come back up. So with all that, I'm just kind of looking to see how well it looks like things are moving, if anything feels like it's really like off kilter.
Okay.
And everything looks and feels fine.
Yay.
So now what I want you to do is try to bring your right knee up towards your chest.
Okay.
And it doesn't actually have to go that high. Perfect. And then come back down. Any pain there?
No.
Good. And then go ahead, lift the left knee up. Perfect. And then back down. Any pain or discomfort with that?
No.
Perfect. So it looks like all this is checking out here. So sometimes if somebody maybe had a history of back pain or injury, we might find something that looks like, maybe that's contributing to why their pelvic floor
is doing what it's doing.
Exactly.
Gotcha.
Sometimes if people are really hypermobile and really flexible, sometimes the pelvic floor also tries to sort of grip to do too much work because it's trying so hard to stabilize. So sometimes as we watch people move, we can start to tell like, ooh, like you're super bendy.
Yeah.
Maybe that might be part of what's going on.
Okay, cool.
So yeah.
All right, great.
So next thing we would do is I would get you lying down on the table so I could assess a few more things.
Okay.
Go ahead, straighten your legs out. So then we may assess just sort of the back and the hips and the SI joint to see how things are doing. So I want you to relax this leg. And now try to hold it there. Good. Any pain as you do that?
No.
Perfect. And then if I bend you up like that, any pain there?
No.
Good. And then if I press down like that, any pain there?
No.
Good. And if I wiggle you like that, any pain there?
No, it's actually kind of nice.
Good.
It's like a massage.
Any pain if I do that right there?
No.
Good. Any pain right here?
No.
Good. And if we kind of cross your leg like that, any pain with that?
No.
And if I press on you there, any pain there?
No.
Perfect. And if I pull on you like that, any pain there?
No.
And if I push on you like that, any pain there?
No.
Perfect. So nothing glaringly obvious going on this side. But again, if we did our assessment and we found a positive test, then that again may kind of clue us in like, ooh, there's something going on with the hip that may be impacting
I gotcha.
what's happening.
Okay.
So I would repeat the same thing on this other side.
Okay.
I don't think we have to do that for
No,
purposes
I
right
think
this second, but it would be just a duplicate over on this side.
Okay.
And that's most of the external assessment that we probably would be able to get through at our evaluation.
Okay.
Then we would potentially do that internal assessment that we talked about, which again, we're not going to do today.
Okay.
But we can do a little bit of an external assessment.
Okay.
I'll often ask people, do you know what a Kegel is?
I do.
All right. So a Kegel is when you're squeezing your pelvic floor and it helps to close off if you have a vulva and a vagina, both the vagina and the anus, so that the muscles are closing and lifting to support you. But a lot of people don't do them well, which is why I have a full-time job. Go ahead and just do your version of whatever you think a Kegel is, okay? And then relax completely. So what I'm looking for is to see like how much is your body moving? Because if I can see you doing a Kegel, probably there are some other muscles that are contracting that we don't want to contract.
Oh, so I did it wrong.
So a Kegel should be like almost like a secret hidden exercise where like nobody knows that you're doing it if you're doing it well.
You do one.
Maybe you look like you're concentrating, but anyways, no. Okay, so.
She smiled. She smiled. Okay, so you just did one and you didn't move at all.
Yeah.
Okay.
But a lot of people, again, will, and it's normal that the abdominal muscles will contract a little bit, but sometimes the muscles will contract too much. Or sometimes people will squeeze the outside glute muscles and they start to like raise up in their seat.
Which just happened to me, yes.
And that happens with a lot of people. Again, it's why we have a job and it's why we are in business and do things.
Okay, good.
So we would do that and then I would coach through, okay, I saw you moving some extra things. Can you try it again, but this time try not to lift off your seat?
Okay, here we go.
And the cue that makes everybody laugh, but it works like
a champ.
It really does.
Okay, what is it?
It's like the vagina and the anus are drinking out of a straw. So it's like a...
Wow.
It's like a... So closing and lifting up and in. Just get that visual. And then just let it go.
Okay.
Yeah.
I feel like it wasn't very strong.
That's okay.
Okay.
Most people don't have a really hugely strong pelvic floor. Hopefully they're functionally strong, but it's not a big muscle group that's contracting.
I see.
And a lot of times when we're doing that bigger contraction, again, it's other muscles that are doing too much work. But imagine that you have to cough, laugh, or sneeze and you don't want to leak.
Yeah.
If you're squeezing all of those other muscles, you actually may not be squeezing your pelvic floor well, and or you may be squeezing so much here that it's actually pushing urine out instead of holding things back.
Okay.
All right.
All right, cool.
The other thing that I'll sometimes have people do is just like sit on their hand. So I'm going to do it too.
Okay.
So take your hand and just kind of do palm side up, and then just put it right up underneath you. So your fingertips are just approaching your pant seam.
Okay.
Okay.
Got it.
Just kind of curl them up just a little bit. You're not going to feel much just other than like tissue, like squishy tissue.
This is fun.
Yeah, it is. It's a good time. You should do this too. Not if you're driving. Okay, so close your eyes. Try to do your Kegel again and see if you can feel anything happening where your fingertips are.
No.
That's okay.
Is that bad?
Not necessarily. It may mean that there's some weakness. It's also a really not reliable way to assess things.
Okay.
But
I'm doing it.
But it's a way to assess things. And then sometimes I'll have people just even like tap where your fingertips are to kind of help your brain reconnect to things.
Okay.
And then try to see like, can you squeeze? And then when you let go, can you feel anything kind of relax?
This is really hard to coordinate my brain to do this.
No, it really is.
I'm squeezing around it.
Yeah, that's okay. And then a lot of times it's hard to feel the squeeze, but you might feel the relax.
I do feel the relax.
So you were probably squeezing.
Okay, great.
And again, it's not the most reliable way to assess things, but for somebody where an internal assessment isn't going to happen for whatever reason,
It's one way.
It's a way to at least start the conversation and start talking about it.
Well, so let's say you need someone to do Kegels. I mean, is that something you would prescribe for someone who's leaking?
Yeah, potentially. So, and the tricky thing is I think for a lot of years, Kegels were like the only thing out there.
I've heard I'm supposed to do like 100 a day, which is daunting.
And has anybody ever told you how to do them?
No. Yes. I mean, I used to teach yoga, and when I was being taught how to teach yoga, they told me to close all my holes.
Close your holes.
Yeah. And that was the
close the holes.
Yeah.
Okay.
The coaching that they gave us, which, you think you're doing it. Although I did have one teacher teach me one trick, which was to lay on your back and put your knee and lay with your feet on the floor, knees up, put a throw pillow in between your knees, and then do a Kegel, and then have someone try to pull the pillow at the same time, and it lit up a muscle I didn't even know I had.
Yeah, so that's kind of using like an overflow technique of trying to get other muscles in the area. So I mentioned we don't want to see other stuff contracting.
Right.
For some people that are maybe just weak and can't tap into the muscles, sometimes we may want them to recruit other things to kind of help get the pelvic floor. So that's one of those tricks that sometimes helps things kind of...
Like you're like, oh.
Yeah, without your brain having to make that conscious connection, it just kind of happens.
Okay.
And that's what your pelvic floor should do. It should just work. It's doing all its things, so you don't have to consciously think about it.
Yeah. And so with your patients that come in,
Yeah.
is it always women? Is it always women who have had children?
No.
No, so
It's literally any human with a pelvis. So the youngest patient I have is a 5-year-old little boy.
Oh,
and then I know, right? And then the oldest patient I have, I think she's a 95-year-old female. But we see men, women, people who are transgender. Maybe it's after they've had a gender confirmation surgery.
Oh, that makes
Maybe
sense.
it's just unrelated to that.
Yeah.
We work with children, again, a lot. We're seeing many more kids in the clinic than we used to.
Okay.
And it's really for just any smattering of issues.
Well, and I feel like pelvic floor therapy has gotten more prominent. Like when I had my son.
People are talking about it more.
Well, when I had my son, there was issue. I have #MomLife, which was like I went to a trampoline park and there needed to be poise pads.
I honest to God, I'm always like, I just want to like pass out business cards there.
Yes, just bring a box of poise pads and put them in the bathroom.
I can't tell you how many patients I see for the first time because they're like, it was that 5-year-old birthday party.
Yep. But that didn't start happening until after. And so it was concerning to me.
Sure.
And I brought it up, but no mention of pelvic floor therapy.
No, because also I think our society has gotten really used to like, oh, that's just what happens when you have kids.
Yes.
Like, you've gone through menopause later in life and like now this is just what happens.
Is it our society or our male doctors?
It's a little bit of everything.
Yeah.
Because even I think there are a lot of women who have just started to accept that this is the way that it is because
sad.
And people's parents had issues and grandparents had issues.
Yes.
So now it's just people think that they have to have these issues because this is just...
Yeah, because you talk to your mom and your mom's like, this is just what happens after you have a baby.
Which is true. It does happen and we can do something about it. So if we've identified that there's maybe a hip weakness that's maybe part of what we think is going on with your pelvic floor, we may give you some hip strengthening exercises. So there's a million different exercises we could do, but this is one of the ones that we might choose.
Okay.
So it's a sidestepping exercise with a resistance band. So we've tied this resistance band just around your legs, just above your knees.
Okay.
And what I'm going to have you do, you can stay just like that.
Okay.
So face me still. Yep. And then gently kind of bend your knees. Good. Lift your chest up. Do a tiny little belly button back to spine squeeze. So you don't have to tilt your pelvis, but just kind of gently draw in.
Got it.
And then keep that as you step to the side. Stay low, almost like there's a ceiling and you don't want to hit your head.
Okay.
Yep. And then keep moving this way. Yep. Good. And you want to try to keep your hips forward.
Oh.
Yep. Sometimes the hips want to start to kind of rotate out to the side. So you want to make sure we say like headlights facing forward.
Now go this way?
Yep, exactly. And you just kind of stay low.
Forward. I'm just going to do this.
You got it. Beautiful. Yep.
All right. Oh, this
and
is
again,
actually getting hard.
Yeah, and it's working on functionally strengthening the hip muscles, and it's a weight-bearing exercise, so it hopefully translates more through to like functional activity as you're moving and doing things.
Okay, cool.
So we may do some other things to kind of incorporate the rest of the deep core musculature and maybe the hips as well. So I'm going to have you lie down on the table now.
Can I take this off?
I'm actually going to have you keep it on. And then what I want you to do here is separate your feet a little bit more. Good. And then you're going to do that little gentle belly squeeze. You're going to keep your knees pulled apart a little bit so you have tension on the band. And now lift your hips up in the air. So it's a bridge. Yep. And then back down. Good. And I'll have you do that just one more time so you can kind of feel it. Yep. Then back down. Now I want you to bring your hands up to here. So arms are straight. Good. Your arms are going to stay straight. Come all the way down to the table as your hips lift up. Yep. And then arms back up. Good. One more of those. Good. And then back up. So now I'm going to have you grab onto the ends. So right there-ish.
Okay.
You're not going to let go, otherwise it's going to hit me in the face.
Okay.
But you're going to do the same thing. So you're going to keep your arms straight, bring your hands all the way down to the table. You got it. Good.
Okay.
Yep.
I feel like I'm in a Pilates class.
Yeah, you are kind of. And it's forcing you to kind of kick on some other core muscles. This is not an isolated exercise by any means.
Okay.
But it's starting to kind of strengthen the hip, the deep core.
All right.
And getting a little bit of the whole team working.
Okay.
Do one more. There you go. Good. So that's another version of something that we might do, again, if we're on to more of the generalized lumbopelvic and hip strengthening, kind of away from the specific pelvic floor.
So how many times should I have done that? Like if I had those issues, how many times, how many reps would I have to do? How often?
I know. So the really very PT gray area answer is it depends.
Of course.
But I will say, as like a general rule of thumb with any type of exercise, doing 2 to 3 sets of 10 repetitions and kind of working through your exercise program. And once that gets really easy, you can start increase your number of repetitions, maybe increase your resistance or increase your weight. So a 2 to 3 sets of 10 is kind of a nice round place to start.
Okay.
But let's say you could only do 5 and then your form
just
was awful or it was painful.
Yeah.
That I'd say 5. 5 is your number. And we're going to do maybe 2 or 3 sets of 5. And that's where we start. And it looks different for every person. That's why I said it depends.
Yeah.
And none of the exercises should ever make things feel worse. That's another thing. I think a lot of times people think of physical therapy and they think like no pain, no gain. But especially when we talk about the pelvic floor, we want to really fly under the pain radar as best we can. So we want to find other ways to move. And there's no right thing or wrong thing or good exercise or bad exercise, but it's really how you do it.
Okay.
And how you feel when you're doing it and how you feel afterwards.
Got it.
So
well, now we have a ball here.
We've got a ball.
Okay.
So I'm going to have you sit on the ball and face that way.
Which way?
Let's go this way. Yeah, just like that. So this ball, this is actually one of my favorite exercises.
Just bouncing?
You get great feedback into your pelvic floor.
Oh, really?
Because you're bouncing kind of right on top of it. Oh. So for my patients who have issues with leaking, I might actually have them, once we've kind of worked on what is a Kegel and how do you do it, I might have them do a little bit of a Kegel and now bounce.
Oh, yeah. Well, I feel like a kid.
There you go.
Okay.
And then I may have you keep bouncing, but try to relax your pelvic floor.
Okay.
And then I may have you try to squeeze it up again.
Okay.
So that may be one of them that, again, kind of mentally gives some feedback. Another thing we might do is some pelvic tilting on the ball. So this ball, technically when you're sitting on a ball, you want to be kind of at like a 90-degree angle with the hips and with the knees. So you're maybe just a tiny bit low. Probably if we had this inflated a little bit more, it would be better for you.
Too heavy for your ball?
No, I'm saying our ball is like way too squishy.
I'm kidding.
You're perfect.
Oh, thank you. Okay, so I'm sitting on the ball, 90-degree angle.
You got it. So for pelvic tilting, your chest is going to be upright. You're going to do that little gentle abdominal contraction again. Yeah, perfect.
Over there.
Do that. Yep. And then what I'm going to have you do is tuck your tailbone under, almost like you're bringing your pubic bone up to your nose. Yep. And then I'm going to have you arch your back and stick your butt out that way. Yep.
What is this strengthening? It's
getting a little bit of everything again. It's not an isolated exercise, but it's getting kind of some of the deep core. It's getting some of the rectus abdominis muscles, that six-pack muscle in the front. And you can consciously think about drawing the belly button back to spine. You could even think about maybe bringing the Kegel in with it and then relaxing and letting it go.
A lot to think about.
It's a lot of moving parts.
Yeah.
So again, we may not start there with somebody.
Yeah.
But if somebody has a ball, loves a ball, is motivated by the ball, we'll try to do as many things on the ball as we can.
Okay. So that you could tell I lit up when I sat on it.
You loved it.
I'd probably be a ball girl.
You would, except I will say almost like 9 out of 10 times I ask them, do you have a ball? And they say yes. And I say, do you know where it is? And they're like, no. Or it's deflated. Yeah. Or I gave it to my mom.
Yeah.
So, but yeah.
Okay, well, that's great.
So those are a few. And again, exercise repetition. it would depend.
Yeah, it depends on the people, but we'll start with like,
Yeah.
like 2 sets of 10.
Yeah, I think that's like a nice, easy place to start. And if it feels way too easy, you can increase it quicker.
Right.
If it feels hard, we can always back it down.
Right on. All right, well, I feel like I learned a ton today. We went from models to assessments to exercises.
We did it.
I feel like I know you at a really deep level.
Absolutely.
Thank you for letting us come today.
Yeah, thanks for coming.
And it's been eye-opening for sure. Y'all, that was so much less awkward than I imagined. I hope this gave you a clearer picture of pelvic floor therapy and helped you see it as a form of physical therapy, and it's nothing to be embarrassed about. Jen Harrington was our fabulous therapist, and you can find her at wakemed.org. We'd love to hear from you. Send us your ideas for future episodes at WRALFM.com/SarahHasQuestions. See you next time.